different 5 components about a good history. For example, especially to be able to arrive at a cardiac diagnosis, it includes a cardiac history, physical examination, which we will be learning in today's and the next session. ECG, we already spoke about it. Chest X-ray is similarly very important thing as well. And of course, if we try to add it up together with the cardiac diagnostic lab tests, then we will be able to complete the cycle of able to have a good diagnosis for the patient. A history needs to have 2 things. It has to be concise and it should be able to cover the important points. Important points, it means is you should be able to take a simple statement, especially using the patient's own words. And I would really like everyone, I think, even for me as well, I try to avoid any leading questions. So unless and until, yes, there are other ways to be able to inform, to get the information from your patient. So other than that, always important thing is if there's any vague point, you should always try to clarify with the patient. And yes, if there's some gaps as well, try to ask always neutral questions and simple, direct questions. And the question should be leading questions, okay? So one of the important component for this is, as I had already said, it is first thing is, what about the personal data? Personal data, what does it include? Personal data, as I had already said, it will include his name, age, sex, occupation, where do you stay, and what are the chief complaints of the patient. And it is important that it should be taken in the patient's own words as well. Then you try to come about the present history. It means the detailed history of the patient's present illness, which must provide answer to the following questions, like first is duration. So how long it has been there? Then what are the modes of onset? So for example, is it acute, subacute, or is it really a chronic problem? Then what about the sequence of events? Sequence of events, for example, like the course. Is it progressive? Is it regressive? Is it happening again and again? Then the appearance of new additional symptoms or disappearance of others. Then, for example, what about the treatment? Has that person received any treatments during the course of the response as well? And of course, you have to try to analyze each particular symptom. And a good past history is also very important for such patients, in the sense you have to ask the history of childhood diseases, any trauma, or if there's any history of travel abroad, or maybe drug therapies, operations, any surgeries the patient has had, or what about those any cardiac illnesses or non-cardiac illnesses? Similarly, about any history of recent dental work or prior cardiac surgeries as well. So once you have known all these things, so then you can try to ask about the habits. So does that person smoke? How about the alcohol intake? So I even, especially in cardiology, I even try to ask how much of tea or coffee. Anyone would like to say why is it important, especially in cardiology, tea or coffee? Come on, you all know the answer. You all know the answer very well. Good, caffeine. So what happens is a lot of times if someone is taking really high amount of caffeine or tea as well, so they will be having high chances of palpitations. So similarly, alcohol history. So for example, there are nowadays newer studies in which paroxysms of atrial fibrillation can be precipitated by intake of alcohol. So this is important. Then, for example, if someone is having a cocaine history, or if someone is having a history of IV drug abuse, then you should start suspecting infective endocarditis, isn't it? So that's why each and everything has a very important thing. Similarly, About the family history. Family history, why do we ask? Because of the genetics or the hereditary factor. Then how about exposure to any of those etiological circumstances as well? For example, um, yeah, if someone's father is a smoker, so there's higher chances of what is called as a passive smoking. So the partner of that person or the kids as well, or those family members will have a higher risk of development of coronary artery disease as well. So what are the different factors, risk factors for coronary artery disease? Anyone would like to try? Please feel free to use the chat box. So cigarette smoking, I already said it, something like hypertension, hyperlipidemia, or even the family history, or the history of diabetes mellitus itself. So these are predisposing factors, which is going to increase the chances of development of the coronary artery disease, isn't it? So one of the other important things is, this is very important, I would say, later on, once we'll be going through the general physical examination. So what are the different symptoms? Patient can have different symptoms, and how you will be able to use or visualize. So this is a very good thing to know. Where is the cardiac border? As you can see it over here. We'll discuss about it further in the general physical examination as well about it. So what may happen is there can be different symptoms. Symptoms may include secondary to lung congestion, which will include something like, so what are the symptoms which one can come across due to lung congestion? Like breathing difficulty, acute pulmonary edema, cough, hemoptysis as well. And in fact, if there's history of recurrent chest infections, there's again problems one has to think. Then not just the lungs, but what about the other symptoms of the systemic congestion? So the systemic congestion patients are the one who can have pain in the right hypochondriac region. So for example, the area where the liver is there, then the dyspepsia may happen. So for example, acidity or gastritis, which may sound a little bit similar. Then there can be swelling of the lower limb and the swelling of the abdomen, or even oliguria as well. Oliguria, the patient will be having complaints of low urine output. So one of the other important things, being in cardiology, I would really expect we all to know is a lot of times there can be signs or symptoms, of course, due to the low cardiac output. Low cardiac output. So what will be happening is due to the the tissue hypoxia, it is going to indirectly affect the various organs. What are those organs? Brain, muscles, kidneys. So that's why those symptoms will happen. So through those symptoms, what will happen if there's low cardiac output to these organs? So there will be easy fatigability, there will be cool, clammy skin, low blood pressure, dizziness, or even chest pain, or someone will feel like I'm about to faint as well. So what about the chest pain? So the chest pain itself, chest refers, so chest has lung as well, the heart is there as well, there's bones as well, there's muscles as well. So of course it can be cardiac origin, it can be again non-cardiac origin, about, as I said, those other organs. So what will happen is the cardiac, so what are the possible causes for chest pain? Anyone would like to try? Please use the chat box. Okay, good, good. So as you all rightly said, it can be ischemia, pericarditis, it can be dissecting aorta, aortic aneurysm as well, okay? So there are multiple causes, and that's why we all are there to find out those reasons. So similarly, as I already said, there could be other causes like the chest wall, neurological, mediastinum, diaphragm, or the abdominal causes as well. like from the esophagus, stomach, gallbladder, or pancreas. So these are very common. So as I said, it is, so if there is a patient who comes to you with the chest pain, so we must ask, how about the site? Is it localized to the cardiac region or is it somewhere else? Then how about the onset? Is it gradual in onset? Is it sudden in onset? Similarly, you have to ask again for the character of the pain. Is it crushing? Is it pressing? Is it burning? Is it heavy, tight, dull? Or is there any radiation of the pain as well? So, as we all will recall, that most of those typical cardiac chest pains will be radiating sometimes, to the left shoulder, I mean, left hand, otherwise to the shoulder as well, sometimes, or even to the jaws as well. Okay. And what about the associated symptoms? Associated symptoms will be like sweating. Is it there? Is there any associated breathing difficulty, nausea, vomiting, or palpitations? What about, did you feel any paleness as well? So, for example, the chances of having someone having a typical heart attack with sweating or nausea, vomiting tends to increase. But with vomiting and all, you understand if there's also about gastroenteritis. So yes, one may have a little bit of sometimes chest discomfort, maybe vomiting as well. So it is good to ask more and more questions. So even about the timing. So what happens is a lot of times the typical acute coronary syndrome, if it tends to happen, is it happens most of the times in the early morning hours of the day. Anyone would like to say the reason for that? Why does it happen in the early morning hours? So what happens? The sympathetic tone in the body is one of the maximum during that time. So which will be causing the vasoconstriction of the coronary vessels. So if there's already any little bit of blockages and all, so it is going to, of course, it is going to make it even more. So that's what can make it really worse. Okay, so now you all are able to understand what about the chest pain. So there could be other problems as well. So there could be other problems. So for example, like shortness of breath. So if there is shortness of breath, similarly, you must ask, okay, how long has the pain, the shortness of breath has been going on? So for example, what makes it better or what makes it worse? Isn't it? It is important to be able to understand. Similarly, you can anyone would like to tell me a grading scale which you normally use for shortness of breath or some classification? Okay, okay, good, wonderful. So there are various classifications which can be used. For example, if it would be, if we know the etiology, if it is for lung, for COPD, what is the classification as it is used? For the COPD, it is Gould classification. However, for shortness of breath, normally we can use is the NYHA, New York Heart Association, class 1, class 2, class 3, class 4. So if someone is having shortness of breath, even on rest, you can call it as class 4. Okay. So other than that, as I said it, yes. So how about exertion? Is the exertion also affecting the shortness of breath? And as I had already said, it is what makes it better. So for example, if someone says, whenever I use an inhaler, I really feel better. So you will be able to understand most of the times it is most likely related to the spasm, bronchial spasm. Okay. So what about the other symptoms patient can have? You may have come across something like ankle edema or even sometimes fainting as well. So what are the things if you ask about the ankle edema? So there are a lot of things one needs to ask. I'll try to give you a hint. Any medication history would you like to ask? So something like diuretics. So if someone is already taking water pills or diuretics, you may not be able to see ankle edema on a clear basis. Okay, and similarly, if someone is taking a medication, something like amlodipine, amlodipine can also itself cause the ankle edema as well. So always try to take a history, like if are you taking any amlodipine as well for your hypertension or some other thing as well. So sometimes yes, and not just that, you should also ask like when did you notice it? When does it worse become? Is it unilateral? Is it bilateral? Because you may have to rule out sometimes like a DVT or any cellular edema or infection as well. So then further you ask like how about any pain? And then is it um, is it of recent onset, or did you had any history of flights as well? Did you take any flights? Because if I'm sure you all know that with increase of flights and all, or activities in which someone has not moved around for long, the chances of DVT or even pulmonary embolism is going to increase. Then if someone gives history of fainting or dizziness, you have to ask the frequency, how long does it last, is there any trigger factor as well, how does it did it make you feel better, then how about any associated loss of control of bowel or bladder movements as well. So that will be further essential as well, isn't it? So one of the common complaints, if you're going to be there in the cardiology, you will come across is the palpitations. So what are the questions you have to ask? So I tend to ask like how frequently is it happening? How long does it last? And then how about the onset? How about its termination? Okay. Then and how frequently does it happen? So does it affect your daily living? Yeah. And as I had already said, it is how about the associated intake of too much of tea, coffee, or alcohol as well? So these are very important things as well. And as I had said, it can even sometimes even help you differentiate. So for example, someone says irregular palpitations. So irregular palpitations, you can think of maybe atrial flutter with varying block or maybe atrial fibrillation. If someone says regular palpitations, then there are a lot of things as well. Then similarly, if someone says you felt like almost becoming unconscious, so then you may have to start thinking about like a ventricular tachycardia and or even other life-threatening arrhythmias, which we already spoke during the ECG sessions. So after all these things, as we already said, it is you should confirm the family history, the social history, and also about allergies. Allergies is something a lot of times which we may miss, but ask them about the respiratory problems, or is there any musculoskeletal problems, genitourinary, or the neurological problems as well. So on an overall basis, you have to analyze these symptoms: site, radiation, provocation, relaxation factor, how long did it last, how is the character of the discomfort, and the associated features as well. So regarding the coronary artery disease, we must focus, especially being in cardiology. So some of the golden pearls, if I would like to say, is like we should remember not all the patients will have the classic textbook symptoms. And yes, angina doesn't always mean coronary artery disease. We must have a high index of suspicion to rule out the diagnosis of acute aortic dissection. And yes, not all myocardial infarction patients will have ECG changes. So can someone tell me what are the three type of patients which can have silent myocardial infarction? So what will happen is you're examining someone and all of a sudden you see changes in the ECG. Huh? And you ask the patient, did you have any chest pain, discomfort, sweating, anything at all? Patient, no doc, I didn't have it. And you are like, well, why am I able to see these changes on the ECG? So you see big Q waves in the inferior wall, 2-3 AVF, which we had already shown you in the last session on the ECG. So the three patients will be is elderly people, because their neurons can degenerate. So that's why they will be having a higher threshold for pain. Second is diabetics, because again of the effect on the neurons in the diabetes due to part of neuropathy. The third one, anyone would like to try? You all know the answer. So at least these three group of people, I always ask these people to be careful, little bit extra careful, is the woman. So women may tend to have a higher threshold for pain. So a lot of them tend to even ignore those symptoms. So that's why these three people don't miss out on these symptoms, I would say. So similarly, there can be a lot of symptoms which may be happening due to rate, rhythm changes. So as I had already said it, try to ask them about the time, mode of onset, offset. Does it relate to the exertion? How about the duration? And I already emphasized about the regularity or the irregularity as well. You may also come across those symptoms which will be causing, if you may recall that picture which I had shown you. So for example, if it is pressing on the esophagus, then you can have difficulty in swallowing and all as well, if it is pressing on the bronchi. So if you will go through some of those publications about atrial fibrillation treatment, I had proposed, we were able to discover symptoms like hemoptysis. When you are trying to treat atrial fibrillation by trying to do electrical isolation in the heart, those patients were coming to the hospital with coughing out of blood. Isn't it strange? You're trying to treat in the heart, but the patient is coming to the hospital with complaints of hemoptysis. So what could be the abnormal reason for that? So then we sat together, we went through everything and all, we went through the anatomy, physiology of ablation, especially cryoablation as well. Then we realized whenever we freeze in the heart, there will be ice ball formation, which will be affecting the lung tissue as well. And due to the lung tissue freezing and defreezing, it is also going to damage the lung tissues, due to which there will be breakage of the alveoli and which the patient will be coughing out. So that's why a lot of those patients will be having these kind of symptoms due to the surrounding structures as well. So don't forget that. Okay. Then after that, nerves. Okay, the nerves as well. What about those nerves which is there in the neighborhood and all? Then the spine. So a lot of times it may happen if there's some problem in the vertebra or maybe even the bones as well. You will be coming across these kind of patients uh, with coming to cardiology, thinking that, okay, this is a cardiac pain. But once you go through all these things, step-by-step approach, which I said it to you, I'm sure you will be able to differentiate that, okay, which is a cardiac pain and which is not a cardiac pain. Anyone would like to comment on this picture? What is this? Okay, simple thing. Is it a cardiac patient or a non-cardiac patient? And what is the reason? I remember a very beautiful story about, I think you all will be aware as well, about Sherlock Holmes and where he used to work, like how the concept of Sherlock Holmes came. So its creator was actually working in the clinic of Arthur Conan Doyle. So he was a doctor. So the way in which this doctor used to ask these questions to his patients and all, the author, the creator of the Sherlock Holmes, got really, inspired actually. This is how the Sherlock Holmes concept had come. So it means is you need to be a good detective as well. So if you look at this picture, there are some, okay, I will give you some hints as well. There are some arrows. There are a lot of things in this picture. By looking at this, you have to try, is it a cardiac patient or is it a non-cardiac patient? Of course, I think Um, if we are talking about this picture, when we're thinking about the history and examination, so it is a cardiac patient. Now you have to tell me the reason why. Why do you think, or what makes you think? You all have to be a good detective. You all have to be a good Sherlock Holmes. So some of the things what you can notice is he's puffing out, isn't it? And then there's some swelling as well. And most likely his peripheries are a little bit cold. And he has tried to put it on a higher elevated point using his pillow. So there is some swelling as well over here. And then what is happening is the door of the toilet is open. So what has been happening is he has been going frequently in and out, in and out. And his body also appears to be swollen. Look at his hands, if you look carefully, and this tummy as well. So especially his hands. So there is a lot of, so what it means is, so this is a patient of congestive cardiac failure and who is already has been started on most likely water pills, okay, diuretics. So this is the beauty of the cardiology. If you take step-by-step approach, thinking on an overall basis about the patient, you will be able to diagnose well. So that's why, first of all, as I said, it is history is very, very important. And then comes one of the most important things, what is called as the cardiovascular examination. So cardiovascular examination, so this is supposed to be, so that's why on an overall basis, I said it, a good history leads to good diagnosis. So examination is more like you're trying to just confirm your diagnosis. You have already made a picture by going through everything and all.